from one to the other, or potentially shunting that channel, or at least half of the channel. And this is a common mistake. So if I'm using 2 points, even if I'm using, say, CZ, I'll put 2 intradermal pins in the scalp from my cephalic and non-cephalic reference studies, so that I in no way shunt between preamps, between channels. If you look at some of the techniques described, especially Choppa's work 5, 6, 7 years ago, you know, he would say, well, you use, say you wanted to stimulate the left ear, you would use a montage CZ2, mastoid, or auricle. Then for bringing out certain potentials, you want to bring out 5, you want to bring out 1, you want to make these things a little easier to see, they would do a horizontal pair, they would use a contralateral pair, things like that. And what happened was people were only setting up 3 electrodes and jumping them box to box. And literally, if this is active on one and reference on another, and I'm shunting them, and then taking this as active in 2 and shunting them, and this one is cross in another, you are literally just putting a short across half of your preamps. And what you end up getting is either garbage, or you'll average internal noise. And don't forget, anything that's time locked gets averaged. And so it becomes very unreliable studies. Specifically in brainstem studies, if I need multiple channels like that, only because of the proximity, if it isn't convenient to set up multiple pins, or if the patient just isn't as compliant as I would like, then in fact I'll run 1, rerun, rerun, rerun serially. And I don't shunt at all for those studies. Okay. Any questions so far? Great. When doing somatosensories, you want to keep the bandwidth pretty much wide open. I usually run with my lower frequency at about 5 hertz. Some people, probably more of a purist than I am, will say you run it at DC, half a hertz or less for your lower filter, okay, your high pass filter, which is your lower setting. I'll typically clip my upper limit, my low pass filter, at 1500 to 2000 hertz. Again, some people say you should default the machine at whatever its capability is, 10,000 hertz, 30,000 hertz, whatever it might be. Run with it wide open so you're not inducing any dispersion by filtering. Especially in the short latency studies, you induce a latency shift the tighter your filter. That's why your brainstem studies should be wide open, and you can get away with, for the visuals, a fairly tight band passing. Is everybody here familiar with what a filter is and how it works? A little bit? Okay. They're basically active and passive filters. An active filter, well, let's start with the passive, because that's your standard. They used to be called pi filters because it was a resistor and capacitors arranged in a square configuration, so it looked like the Greek letter pi. What that does, it doesn't actually remove a signal. It can't. What a filter is a timing circuit. And what it does is it takes part of that signal and slows it down. And that's all that it does. It is not removing it, it's time shifting it. That's why they refer to the filter capacity often as a timing circuit. And so the thing to keep in mind is that you are not eliminating a signal by filtering it, you're moving it downstream. The more you filter, the more percentage of the signal is moved downstream. Now, if you're interested in something that happens at 10 milliseconds, for example, and you clean up your signal to see a nice piece of information at 10 milliseconds, you might find that what was a nice clean signal at 20 milliseconds is now got multiple peaks. And that's what you're doing, is you're taking part of that energy and moving it down. So in fact, you're distorting the signal. And the further downstream you go and the tighter the filtering, the more dispersion and the more deformity you're inducing in your response. So whenever possible, wide filters. Shouldn't filter at all for somatosensory, or just minimal filtering to clean up ambient noise. Brainstem studies should never be filtered. It's too fast. You're definitely going to induce a change in the signal appearance. You're going to change your latencies. So if you're going to filter, say you're in a lab that is sitting across from a microwave transmission tower or a radio station, then you're going to have to filter. Then you have to standardize to whatever your filter setting is. And just understand that on a given day, if you clamp down harder, you're going to induce more dispersion. So if the signal, say you do have to change your filters for some reason, just whatever, there are dielectrics in the air, your electrodes degraded and the new sets haven't come in, and you have to change your parameters, just remember that you're going to get changes in your signal. For something like a visual evoked potential, where there is very little change in the baseline, it's a very long latency, there's plenty of time for the filtering effect to be dispersed within the peak. Doesn't change that much. It's not important. There you can clamp way down past between 1 and 100 hertz, 1 and 300 hertz, something like that, and not affect the waveform morphology. Okay. There is very little else that you can change on a machine. You have your gain, you have your sweep speed, your window, and your filter settings. And everything else is pretty much an inherent characteristic of your machine. So your electrode setup, your patient relaxation, and your ambient noise are the other things that you can control. Okay. Should we start with a study? This is a surface clip described in a paper in 1956 by Copeland and Davies, thus the name. They're stainless steel. They're cold sterilized in glutaraldehyde or whatever solution you want to use. Thanks. And they're quick. You just apply them to the skin. They just grab. And that's it. That's the whole Magellan. All right? Then I put a little conductive gel over it. Yeah, just over where the pins touch. And it works. So, by the way, you can use these for peripheral nerve conductions also. Yeah. And I buy them by almost a dozen at a time. I order them through Harvard Bioscience Apparatus Company in Massachusetts. If you call the area code 617, I don't remember the town. I always think of Nyack, but I know Nyack's in New York. Sounds like Nyack, Massachusetts. These come from Europe. These are imported from England, yeah. But the local distributor is Harvard Biomedical or Harvard Bioscience and Apparatus Company. That's the exact title.
So they were first built in England?
Mm-hmm.
They were designed in England? Mm-hmm. There's no company in Europe, I'm sure, selling these. I never saw them.
Really?
I stayed for a couple of months in England, a couple of days, and I never saw them.
They're great. They save a lot of time, and I'm a busy clinician. I want an accurate study, I want a fast study. In that order. It's got to be accurate. I don't put my name on it. And if I can save 10 minutes in setup time 3 times a day, or even more than that, actually, it's important. It's also uniform. But if you measure the impedance, you're going to find that these run 60 to 80 K. And you're going to say, oh my goodness, how can I use something that's 60 to 80 K? Every book that I've ever read says it's got to be 5 K or less. It works. If you have 100 megohm or greater impedance, and some of these machines now are 200, 300 megohm input impedances, looking at an electrode of 80K means nothing. It's one magnitude difference of an 8K. So you're not going to get hardly any degradation in amplitude, and certainly no shift in latency or waveform. Okay, we ready? For the time base, for simplicity, we'll use a cephalic reference. So we'll arbitrarily say just use the right median. Does this machine default with labels and such? I'm not familiar with this equipment.
What type of labels?
Just does it
on the printout.
on the printout it does. Okay. Do you want to give a little blurb about the machine, how it sets up, how it defaults?
What you have with this instrument is 4-channel recording capability. You can get up to 8 waveforms on the screen simultaneously. But what you have is a menu selection. You have the various categories and then subcategory testing underneath those. EMG, evoked EMG, somatosensory, which we're going to be doing now, which fall in with some of your motor studies as far as nerve conductions. But here we have somatosensory, 2 additional, and then one that would be more an ECG type triggered response available, visual, and so forth. Basically, you select the testing that you're wanting to do by advancing your cursor to the category and then come over and you can select the various program. Then you go into what we call our condition mode. This allows you that now to set up all of the various recording parameters you're going to be utilizing throughout the testing. You can name your electrode sites. You can have 2 different time bases that you can program in. You adjust all of the recording parameters, and then they stay in permanent memory once you've selected them, so that now the next time, whenever you come to do that testing, everything will be called up for you automatically. You won't have to go back and reprogram it every time. So here's your amplifier screen. Here's an acquisition screen that will allow you to put in what you're going to utilize as far as the stimulus, your averaging, your analysis time, and so forth.
That and we'll start entering in how the parameters.
Okay.
Okay. We're going to be using one channel. Thanks.
It's your turn.
Okay. We're going to be using one channel, and we'll use C3 prime to FZ.
To FZ.
Right, so we use a cephalic referenced upper extremity study.
Okay.
Do you do them at this point? You're doing them like that?
Okay. C3 is already in, so we don't need to change that.
Yeah. Now A1 would be here. We're not going to use it. I like to use it up here. Or the contralateral acromioclavicular joint.
FZ, you said?
Yeah, FC.
Okay.
All right, and
You just want
sensitivity,
one channel.
right. Sensitivity, can we go down to 5 microvolts? And we'll hope it runs in this room. I have no idea what we're up against yet. High cut, 2500 hertz.
How about we have choice of 1,000 or 3,000?
3,000 is close enough. And anywhere from 1 to 5 hertz for the high pass. Good.
Okay. Now our acquisition. Monitor time is 200 milliseconds.
No, we don't need that. 50 millisecond window is all we'll need. Okay. No delay. Now, in the operating room, as well as under certain adverse circumstances, I have a delay line on my stimulus built into the machine. And with that, on the trace, instead of the left-hand margin of my sweep being the stimulus point, I'll move it in 10 milliseconds. So what I'm looking at is a baseline of pre-stimulus activity. That tells me how much noise is in the room, because that should be flat. So it's a very good, quick way of looking at what you're up against when you're doing the test. So when you set up your delay, is that what it does? It delays the stimulus point on the trace? Put in a 10 millisecond delay, if you would, or a 5 millisecond. 5 milliseconds enough.
Well, ours works according to division, so I can... That would
One
be
division.
equal to-
Perfect. Okay. Trigger. This is a constant current unit.
Yes.
Right. fine.
Preset count.
Mm. 200 sounds fine.
And our reject levels plus or minus 4 divisions, or in other words, 80%.
Mm-hmm. I set mine, I have little toggle switches, what they call dip switches, and I usually set my averager at 90% of full scale.
We have plus or minus 5, plus or minus 4, something like that.
All right, yeah, plus or minus 5. Let's do that. And that would be 90%. Don't forget, that's not 90% of your signal, 90% of the full scale designation. So we might be looking at something that will end up 3 microvolts once it's averaged out. But at the scale we're using, it's going to reject anything that's greater than 40 microvolts. All right, it's 10 divisions. 50. Okay. Okay. Any questions at this point?
Okay, next one is stim rate.
I use very odd numbers. What do you have in terms of control?
It is 97% of whatever's selected. Can you just go here?
Okay. Yeah, 1 or 2 per second is fine.
Duration?
Of the stimulus? 0.05.
0.45.
Mm-hmm. Mm-hmm. Sounds good. Okay. Of course, every test is preceded by a clinical examination and a history. So is everybody familiar with the 1020? Do you have a marker pen? Okay, 2 tricks that I use in my office. I have 2 big art markers that I can that are different colors for different color skin, and I can use them to mark. So when I lay this across the scalp and measure, each side is the overlapping of 2 lines. So I make my cross marks on the scalp and then find it. So a good marking pen is important. The second thing that's important, unfortunately I forgot to bring these, which I have to give my daughter credit for. She wears these big spring-loaded clips, or she used to years ago. You ever see those things that look like plastic ribbons? They wash up easily with hot water. You can use them patient to patient. And when I need to get to an area, I just grab the whole hair like that with these clips, and I have a clean area for setting up the electrodes. So, and they are ridiculously cheap. You get a band of 3 or 6 of them in any 5 and dime for $1. And they're great when somebody's got a lot of hair. Like if I had to separate your hair, that would be the way to do it. What other little tricks do we do? Well, that's basically it. Those are the easy ones. Now, bald people, the less hair you have, the higher the skin resistance. Okay, and the tougher the skin has to be, it's got more exposure. So you'll find that you'll get better skin impedances on hairy people, even though you can find your points more easily with less hair. The skin is tougher, thicker, and has higher resistance. So there, sometimes a little extra rubbing helps. Now, do we have alky wipes here?
No, I don't have it.
Okay, so I'll just spit on the skin and wipe it off with my arm.
But there's some skin prep. That's skin
No, we're not going to use that. Do we have any 2x2s? No, we have some paper towels. Okay. I don't use the skin prep. Using the clip electrodes, what I'll do is just take a 2x2 or an alky wipe and just give the skin a good rub, and that's all you need. Okay? What I'll do is actually I'll take, this is my routine, the alcohol wipe, then I'll put a little conductive gel on a 2x2 and rub it right into that site, and then I hook up my pins. And I get a nice clean study. Now, for an upper extremity cephalic reference, I would not typically use a chin ground. I would use the shoulder. I would use a neutral point somewhere in between the stimulus and pickup. But now I couldn't get to where I need to anyway, so we'll use a chin and hope for the best. Yeah, you're going to have to turn around a little bit and tell me, here's channel 1. I'm just going to use one channel. So we'll just use 3 all told. I'm going to use we're going to use the right median, so I'll use C3 prime and FC. These are my inputs.
Yes.
And where's my ground for that?
I've got ground.
Ground here.
A plate that you could use for the
Okay, good. I'm sorry I didn't bring another type of tape along. I use Blenderm. Do you have it?
There was another cut in there.
Is it stretchable plastic? Now, Blenderm has one tremendous advantage over these others. It's stretchable. If I pull on this too hard, it's going to tear. Blenderm stretches a lot, holds the skin great, and has one advantage in today's world. It doesn't stick to gloves. So I can, with gloves on, tear and apply Blenderm. No, that silk tape is the worst. When you have gloves on, forget it. So, I don't even remember what company makes it. I think it's also a 3M product. It's either 3M or Johnson & Johnson. And has a lot of advantages. I don't have to take my gloves off. I can work with gloves. Yeah. So, okay. Setting up over the median nerve. And as you see, I use a lot of tape.
What's the polarity of the electrode that you guys set on?
I'm hoping that I've got my cathode proximal. Yes. Yes. And a little insurance tape. Oh, that's another thing I'll typically do. Take another little piece of tape and tape it elsewhere. Okay? Just to prevent it from coming off. Now, we'll get our CZ point. Who has a flare? Any kind of marker pen? No, I've also got it's a rolling marker. Okay.
This one is even worse.
That might, let's see how well that one might work. Thank you. Okay, Nasian, pick up your head if you would, please. Around to Inyan. Okay, she's virtually average at 35 centimeters. So 17 and a half would give me my CZ, and we're going to go to 18 and a half. And then I would just make my marks on either side of it like that with the marker pen. Okay? Then we would measure across from your anti-helix to anti-helix. And the measurement is 36, so 18. Notice how I'm keeping it in place. Okay, now from that point, we'll measure over our 20%. So we'll measure over about 7.2 centimeters. 1, 2, 3, 4, 5, 6, 7.2, and right there. Okay, and then I would take again half of my arc distance back, make the mark, and in this situation, measure back 1 more centimeter. So we're going to go back 1 centimeter. Now, one of the big advantages of these clips is I've just hooked it in. And that's it.
Ah! Oh, I forgot.
Wait, no.
Okay, I'll take it off. Okay, it just has to grab the skin. You don't push it in.
Yeah.
It's a skin clip. And that's it. Just grabs the skin.
It's after you cleaned it and prepped and everything.
Exactly.
So,
And then I would use...
It's like a needle, isn't it? Oops.
Yeah.
Same properties in every respect.
That's right. But it isn't intradermal. It's surface. Okay. Don't worry, I cleaned these before I brought them. Okay, and then I would measure back here, get my 20% mark for the FZ, so 7.2, and then I would ask the patient to raise their eyebrows as high as you can. Okay, now you see right where it measured, we're on the edge of the frontalis. So relax now. I would usually go up about 1 centimeter, just to clear. If we didn't have the overlap, I would just set the clip right there.
That's the reference.
That's my reference point. And I would normally use a conductive gel, but this paste is kind of ooky. Yeah. It's good stuff. Should I put some on?
It went off.
Yeah,
Okay.
something came on.
Yeah.
No, it is. It doesn't dry out. It really is. It's
Well,
just lanolin
these
based.
electrodes work without, you put some paste on.
Usually I'll put, now the paste reduces the noise. Now this, I usually use like an EKG paste, not an EEG paste.
It's just an ordinary.
You're lucky. Okay, so now we're going to trigger, we're going to stim, and you see the amount of 60 cycle in here. Now relax. Am I inducing some of it? We're getting a huge amount of interference, so let's stop. Change our gain. Movement of the abductor pollicis. Are you feeling that? Am I looking at the right channel? Stim milliamp A.
Okay, press your stim start on the instrument.
I have it.
Okay,
You feeling it now? 8
now.
milliamp?
Yeah,
There we go.
but it's in.
Good.
I see it
So
work,
it's going into my ring finger.
Is it very strong?
I can feel it's not uncomfortable.
There we go. And a nice brisk twitch. Okay, there's our delay, and now we'll do the analysis. And now just relax. Now, the instructions to the patient. Let your jaw stay loose, keep your eyes open, and just sort of look up over there at the ceiling so that they're focusing down a little bit. So look right over my hand up at the ceiling. Perfect. That keeps their eyes open. The eyelids, the orbicularis, oculi, has a lot of motor activity in it. The motor activity is with eye closure, not with opening. Also, by having them look down a little bit, you're bringing down the frontalis, so they're not raising their eyebrows to look straight up at the ceiling. And a relaxed jaw is very important. And in a position like this, where they're lying down, of course, you've eliminated the motor activity in the neck and shoulders. And we're getting a signal.
200, right?
Now, one of the things that I do is I stop and then I restart. Now, in a situation where the machine is taking a steady stimulus, in other words, it is a fixed period of stimulus, what I've just done is made it aperiodic. By starting it and stopping it at once, I've taken the first, I don't know how many sweeps went by, 100, and in the middle of it, shifted it off the time lock 60 cycle. Unless I was unlucky enough to start it exactly back in time with the 60 cycle. Now it's not rejecting. So at least we're within the permitted range. And you can see the potential coming out again. Does everybody know what the function of the averager is? In theoretical terms, what you're doing is you're improving your signal-to-noise ratio. It is augmented, the signal-to-noise ratio is augmented by the square of the number of sweeps derived or summated. So 400 sweeps is twice as clean as 100 sweeps. To get it twice as clean again, you'd have to go up to 1,600 sweeps. Okay, now I'm going to stop and restart. Again, just to make it aperiodic.
There's some controversy concerning the reference. You don't take both ears, linked ears.
You can. Again, that's another technique.
Okay. But sometimes
But that's usually more for ground than reference.
You said something about using the opposite clavicle or AC joint rather than the chin. Why would you do that? Get it around?
Because, as you see, we're getting a very poor signal. Our electrodes are too close together. And as all the signal is pretty much the same coming up above the...
What couldn't you use your elbow?
Oh, you can, sure. But the chin is still below the foramen magnum in terms of where the potential is. Okay. Now, poorly defined, we've got a lot of noise. We're not using the best or cleanest electrode setup. But here you have a nice reproducible trace with 5, 10, 15. That would be about your 19 and your N23, 22, 23. Okay, so you do have an evoked response.
I'm going to...
You will.
There's also no advantage of using a random input.
A random stimulus? Oh, the tremendous advantage. In a room like this,
Would be.
that's what I wish we
I
had.
want to try it.
Do you have one?
Yeah.
Let me
See over on-
store, got it.
See over there on the top right where it says recurrent, random,
Got it.
press the button down to
Got it, for random. Okay, now we're going to do a random, and now I won't start and stop. Okay, we're off and running.
It's random now.
Oh,
Huh?
I have to erase.
Yeah.
I have a pretty good learning curve. Now we're running, and it's random.
I know.
Random looking regularly irregular.
Explain to me what you just did.
I just changed it from a recurrent stimulus to a random stimulus. So before, we're like on my equipment, I'm used to just in the middle of the test stopping the machine and restarting it. Here, the machine has got a fixed pattern of or irregular sweeps, or has some formula that it uses to mix up the stimulus time.
From 50 to 150.
And what's the advantage of that?
In a very noisy room like this, you're supposedly going to get your best elimination of 60 cycle.
Yeah, I understand.
You wouldn't routinely use your 60 hertz filter?
No. No, I do very little filtering. Filter as needed only. As a matter of fact, Dr. Jewett yesterday mentioned in response to Ted Lieberson's paper that are you sure you're not getting an amplifier signal, an amplifier artifact. I'm going to show a slide. I'll start off my lecture today with a slide to punctuate that point. Okay, now it stopped. Now, so much for random. Yes, I like recurrent, and I like to do it aperiodically. Just turn it on, turn it off one or two times. You get a nice signal. So I have a unit. The machine that I typically use has a completely programmable board. So if I want like a 1.27 stimulus rate, I just type in 1.27 and the computer sets it up. So that's the other reason why I don't worry about it that much. And with that, I'll still start and stop once, even though I'm making it an asynchronous stim rate.
So you interrupt
Yes,
Right.
just stop and restart. Then I know I've covered all bets. Okay. Any questions about the SEP? These are all technically very easy to do when you're doing it as a standard thing. Trick is, though, as with all electrophysiological testing, it's an interactive procedure. You can move your stimulation point and move your pickups as you need to answer a specific question. if you think you're looking at some unusual type 2 or type 3 Guillen's tunnel, well, then you can go across the tunnel with it. You don't start at the rest. You know, there are all different ways of doing it. Just because I'm showing you one technique with one channel, this is not the way it would normally be done. Typically 3 channels, cephalic reference, non-cephalic reference, and an Erb's point marker. Well, what I would use for the Erb's point marker is I would use the contralateral shoulder as reference. Cephalic, I would use just the FZ as you see here. For non-cephalic, I would either use the shoulder or some distant site. Okay, in that case, I would put my ground on the ipsilateral AC joint. Okay, I wouldn't have it up there. I would have my ground over here.
You cannot record from
Mm-mm. No, I'll record from Erb's point. Okay. And sometimes, concurrent with that, I'll pick up over another site, and you can actually get an afferent neurogram over the elbow by putting another bar electrode here and see if there's a dispersion pattern early on in your fibers, things of that nature. I have 4 channels, so that's something I'll do periodically. I'll pick up right here. Especially if I'm thinking of some proximal entrapment, I want to make sure I'm not looking at something subtle going on in the nerve peripherally. I would put another bar pickup right over here over the cubital groove. Yeah. Yeah, for the lower extremities, remember John Kimura yesterday was talking about using the contralateral knee. Suppose we'll arbitrarily use the right posterior tibial nerve. He would use a contralateral knee as a reference and then pick up over the head, and then you'll see your root entry markers come out on the somatosensory study. That's been observed by a lot of people for a long time and just chalked up to that it's the root entry point into the cord, giving some vector that's summating on the potential. What I do is I'll do the electrospinogram at the root entry, over the conus, and I'll do my somatosensory on a separate channel. Now, for perineal, I'll pick up at the knee, or I'm sorry, I'll stimulate at the knee. Posterior tib, I'll stimulate medial malleolus. But for the lateral femoral cutaneous, and sural, of course, I'll use the same thing, a bar electrode. For the lateral femoral cutaneous nerve, when I want to stimulate that area, there is some variation exactly where the nerve is coming out. So what I do is I use my ring electrodes, slide the grommets down, and then I have a nice flexible bar. I'll then measure down roughly anywhere from 12 to 18 centimeters, put a line of conductive gel, put it on, and just tape it straight down over the thigh. And then I'll do I'll do cathode proximal, anode distal, separate them by 2 or 3 centimeters. And that's how I stimulate. Then I know I'm getting it. Right. Okay, so that's a good little trick. Okay, yeah, we'll reset the... Okay, our reference point stays the same. And of course, you all see the CZ point right here. Fortunately, there's a nice measurable vertex. I mean, a palpable vertex. I'm caught? Oh. Yes. And a little conductive gel. I'm tripping on my own wires here. The wrong one. Well, I have a feeling it's not going to get through the nylon with this more pasty one.
what, I've got other stimulators.
What kind of stimulators do you have?
Well, more probe type.
Yeah, I think a probe type would be more appropriate here. Not as long, though. Yeah, we'll fake it with this. So now I'm going CZ prime to FZ.
In here. See the crown here.
It's right there.
Same thing, cathode proximal. And again, don't spare the tape.
I've done it before. Don't worry about it.
Okay. Good. And again, I've taped down this to act as an anchor.
So to be honest, puzzles now.
Yes. Okay.
How much behind the vertex of the TV?
1 centimeter.
1, okay. 1 centimeter.
You ready? Now, I want to change my time base. I'm going to use the same parameters in terms of filters, generally 5 hertz up to 2,000 or 3,000 hertz. Now, I want to change my time base. We're set. Okay. A quick check of the electrodes, just a little, very gentle movement. Guess what? I have them plugged in upside down for what we need. Let's see, I think. Are the color codes right now? Yes. Okay. Okay, and we're going to trigger. Now, whoops, keep steadying on this. If somebody would just feel the abductor hallucis and let me know when it's twitching. Okay, relax, keep your eyes open, let everything go as loose as you can. And I think we've just got too much antenna effect here. It's running, but...
Do you want to try this time plus your skin plate?
Yes, I'll very often put it over the sacral plate. I don't like, or I don't prefer to use the iliac crest, but some people do that. Some people use the knee. Again, the trick is just standardize. We're not getting good,
Can't feel anything.
that's probably why we're not getting good response, among other things. Definitely ask your patients to take off their nylons. No, I'm not really getting... Yeah.
Can you feel it?
Oh, definitely. I can do that. Oh, yeah.
And I just...
I don't feel it twitching, I just feel the stimulus on the bone. This is where I feel it, not really in the muscle. There's no question, I feel it.
Mm-hmm. Yeah, I like the twitch for confirmation.
Feel the twitch.
Mm-hmm. Yeah, that's really your only way of knowing. Now, in cases where there is no twitch, then I'll go to 3 times stimulus threshold. Same thing for the pudendal nerves, 2.5, 3 times if they'll tolerate it. The lower extremities I'll run approximately 1 per second, 1.2 per second, somewhere in that range. If you do it faster, I found that the patients generally tighten up. They can't relax as readily. And Typically, I'll get my lower extremity studies in 30 to 50 sweeps. And say for the bedendal, I'll run 100 sweeps of each just to be absolutely sure I'm getting a clean response. So there's very little difference in the actual run time. If there's a half a minute or a minute difference, it's really inconsequential relative to the setup time. We do a lot of individualized testing then.
Yeah.
There are certain things. We do have an EEG technician who does the brainstem and visual. But there are still times when the doctors in the hospital want me to do it for a variety of reasons. You know, for almost like for doing an audiometric analysis, or if it's part of a multi-study approach, then they'll want it. So. And periodically, the EEG technician will be in the OR actually running. Say we'll get an emergency call, or I'm booked for the day and I just can't do it, then she'll set up, and I'll go in and out periodically and check what's going on. And at the critical times, say if they're doing rodding at the time of the distraction, or if they're doing a CD rodding at the rotations and fixations, or when they cut through the ligamentous flavum and start getting their hooks in place, then I'm in the OR monitoring at that point.
What kind of surgery are monitoring?
Everything from multiple aneurysms to spinal fixation, tumor removals.
Tumor in the spinal cord?
Yes, spinal cord tumors. Multiple aneurysms, where we'll do global as well as somatosensory analysis. Just look at the general EEG.
Within the skull?
Well, within the skull we'll do other things. We'll do the brainstem.
Yeah.
And some somatosensory. So I'll set up for that on one channel, or actually I'll have multiple setups and I'll go back and forth between them. You know, when they have that kind of a situation, getting all your equipment in location as they want to work is the trick. You know, and keeping it in location, even if you use the tubes on your ear set, on your headset, keeping everything in place while they're leaning on the patient and, you know, making their flaps, it's a headache. Putting it mildly, it's a headache.
Some surgeons do not accept any electrodes.
Yeah, it can. Always duplicate your studies. Never accept a single study.
Can you guys see my toe twitching?
Not at all. All right.
It's hurting.
Is it?
That's fine.
All right, then we'll cut it.
No, I'm not complaining. I just wonder if we moved it down a little bit.
Mhm.
Because I'm not...
Yeah, because
We can find a response rate is up to or
well,
yeah.
these rooms are less than ideal. Boy, we've recorded the interference beautifully.
Beautifully.
We'll try again.
There, much better.
Ah, now we're golden. Okay. For this, for the lower extremity, rather than do it as a non-cephalic reference study the way Jung does, I'll do my separate entry marks. So I'll do a spinal entry and a root entry. Okay, the spinal entry at the conus level roughly is at the T12L1 level, and then a root entry at 5S1. And on the scalp, I only use for these midlines.
You do standard on anterior femoral continuous there. Standard EMG never next stage.
Oh, sure, yeah.
How would you do a setup with a two-channel unit?
For the scalp, there's only one channel that I use for the lower extremities. Because I'm only interested in what's going on above the foramen magnum, what's going on below. So I'll use the midline montage like we have here, and for below I'll do the root entry. Some people will monitor with, like the example I gave you of using a pickup over the cubital tunnel. Some people will monitor with an electrode over the popliteal fossa. and pick it up as they come up. I really have never done that. Can't remember ever doing it even just to experiment. But there are a lot of people who say that's another way of getting confirmation and looking at your afferent neurogram as a way of seeing if there is a dispersion in a neuropathic state or one particular fiber dropout. Matter of fact, Ted Lieberson had a nice article about that years ago, stimulating, I don't remember if he stimulated the pinky or the distal forearm, but it was one of those two sites, and then picked up with a bar over the cubital tunnel. With the brainstem auditory evoked potential that we're now going to run through, the electrodes were set up in pattern to do the left ear first. It's arbitrary, and there's no one side that you do in any pattern. We have the electrode set up from the left mastoid to CZ as one channel. That's the main channel that will be interpreted, and the main channel to evaluate for your interpeak latencies, 1.3 and 3.5. We also have set up a contralateral channel from the right mastoid up to CZ as a way of looking at the later latencies, the fourth and fifth peak. You'll augment your fifth peak amplitude. Then we don't have it set up, but you can run a horizontal montage from ipsilateral to contralateral ear, and that would augment your earlier peaks, 1 and 3. The first peak can be augmented the best, though, on your routine channel, in this case, A1 to CZ, just by increasing your gain. And then you would use the horizontal montage as a way of also augmenting 3. Okay, now, normally this test would be done either as part of a screening for systemic conditions like multiple sclerosis, or done in an audiometric procedure of increasing gain on the stimulus as a way of defining hearing problems. And then you would look for the entire complex shifting as well as augmentation of the latencies. Now, we're going to, sure.
What do you think about doing this in post-head trauma cases?
It's fine, and it's also done interoperatively also as a way of evaluating what's going on. The brainstem potential is also used quite a bit in brain death. And there, if you see your eighth nerve potential, your first peak, and nothing else, then you know exactly what you're dealing with. It's a good way of establishing brain death.
Even though if you know the patient had no hearing problems.
Exactly, right. Should be somebody without a known hearing problem. And of course taken into account with all other clinical findings and absent brainstem and cranial nerve reflexes and the whole ball of wax. Okay, we'll put these on.
I think we might have to make them a little bigger.
Yeah.
Nope.
Good. Now, the headphones are color-coded. Right is red. We're not establishing a threshold level, but you should always get a threshold level. And the typical teaching, or the classical teaching, is to stimulate at 60 to 70 dB above threshold, with normal threshold being, say, in about a 10 dB range or less. Then the opposite ear for each study is masked with what's called white noise, or more specifically pink noise. It's low frequency noise. And that's to prevent the ear that's being stimulated, or the noise that's being used, to transmit across the skull via bone conduction into the opposite ear. Under two circumstances. One is if you have fairly good hearing, just average hearing, you're going to get a good degree of conduction, and it's only a 20 or 30 dB loss through the skull. But on the scenario where the ear you're testing happens to have worse hearing, then you're definitely going to get transmission to the good ear, assuming there's an asymmetry. So you want to put in a noise that will not allow the brain to synchronize and give information. Okay. The alternative of going 60 to 70 dB above threshold is to use a given stimulus level. And a lot of people will trigger at 80 or 90 dB. And then use anywhere from 30 to 40 dB less in masking noise on the contralateral ear. And that's what we're going to be doing here. That's what the machine has been set up for. Okay? You ready? Same instructions to the patient before they come in. The hair should be freshly washed. The scalp should be clean and dry. The same instructions also apply that they're to relax. Keep the eyes open. If you see that they're clenching them, let the jaw relax. That's pretty much it. Make sure they have a fairly, that they've had an audiometric exam, or at least examine the external auditory meatus and make sure there's no obstructions or mechanical problems that would affect the test. You hope that they've been screened prior to you setting this up. It's a given. Okay, you ready? Now, the trigger on this one, just stim.
Again, stim starts the stimulation.
And analysis starts the analysis. We have a lot of 60 cycle. Okay, now we're running. Okay, now channel. Are there any other lights that need to be on if we're getting 2 channels of information? Okay, good. Okay, it's running. Okay. Now I've dumped the previous data only because we had a lot of garbage and changing of the parameters, and now we're running and we're getting the information. Unfortunately, the room we're working in is like a ballroom, and there are exposed electric cables draped literally all the way around the room. So the 60 cycle is quite high. Now here on the ipsilateral side, you see the development of the first peak, second, third, a combined 4-5. And here on the contralateral, you see the 4-5. The only additional instructions that I'll give the patient are to listen to the sound. Ask them to literally concentrate on the click. And of course, you shouldn't have somebody blabbering like I'm doing. The room should be quiet. There shouldn't be any distractions. Okay, I'm going to stop, save that, and we'll run again. Inadvertently, I think I lost one of the channels of data. But we'll at least get the ipsilateral side.
On average, you're making how many samples here?
The first set was 600 or 700. With all somatosensory tests, there is a certain jitter in the nerves that occur. And when you average, you will actually lose amplitude the more you average. I mean, ideally, theoretically, under normalization of averaging, it should become asymptotic and stay at a given level. That's in theory. In fact, your digitizer is always taking the low side of each signal, top or bottom, and so it's always reduced relative to the actual. Then you add into that a certain degree of physiological jitter at any nerve, at any synapse, and you'll see that you can over-average and lose your potentials, or blur them. Yeah.
So are amplitudes important here in this?
Yes, they are.
They are.
So we would run the same number, and here we are at about 700. So I would stop, store. To store the second channel,
Press the third button.
Press 3.
Since you lost the...
Got it. Okay. Okay, and let me just bring out my markers. Okay, there's our first potential at 1.58 milliseconds. Second at 256. Third is at 3.41 milliseconds. And the 4-5 complex shows the 4 at 4.83 and the 5 at 5.32. So our difference between them, say the 1.5 latency, is at around 4.8. I'm sorry, 3.8, which is perfectly normal. And here you see on the lower, the contralateral tracing, you get much better separation of your 4-5 complex. Okay, I'm sorry I had lost the other one, but that's why you use the contralateral montage. And then the horizontal montage would give you a 1 and a 3 with a little more clarity. Okay, you do have a brainstem. Any questions about that? Here, impedance is important. This is one of those studies where you do have to balance the electrodes. The other thing that is important is that you don't over-jump your wires. By that I mean that you take a ground from one side that happens to be an active for another channel, and what you'll find is that that active, say we took the ipsilateral ear that we're stimulating and used that as the ground for the contralateral montage, that same electrode, then that one electrode is being piped into the positive grid on one set of preamplifiers and being grounded simultaneously. And so in essence you've shorted it out. So as we did here, each of the electrodes are separate for each of the inputs, and that keeps it nice and clean and fast.
Don't take too many shortcuts.
No, this is one of those tests. No shortcuts. These are your enemy in bears, these little jumpers. Where they do come in handy in other tests, you don't want to use them here. Okay.
Let's start from the beginning. I'm Arminius Kazvan. I'm not responsible for my first name, and I'm here to demonstrate and to make you work, if we have time, on the three modalities: somatosensory evoked potentials, auditory evoked potential, and visual evoked potential. And if I'm not wrong, this is really the sequence. Since the lecturers cannot have time always to speak about basics, I am here to cover basics. Don't expect anything which is beyond basics. So I'll start with the somatosensory evoked potential studies, and I told before that conveniently the evoked potentials are classified according to each type. For instance, in the case of the visual evoked potentials, we are dealing with a type of stimulus. You can classify them according to the fact that the stimulus is a checkerboard pattern, either reversed or on and off, grating, and all other figures. The most adequate stimulus in visual evoked potential, statistically speaking, is the checkerboard pattern reversal. The auditory evoked potentials, which are not only brainstem auditory evoked potential by any stretch of imagination, are classified the best by latency. And you have early potentials, middle, late, and long. The early potentials are from 0 to 10 milliseconds and include electrocochleographic with a potential CM, cochlear microphonic, AP, and summated potential. AP is N1 and corresponds to the first wave of the brainstem auditory evoked potential. So electrocochleogram, frequency following response, or FFR, as the name says, is a potential following the frequency and resulting from a stimulus which is a sinusoidal. And if you listen to Jewett, he mentioned this. And the most important, of course, early potential are the brainstem auditory evoked potential, or the brainstem evoke responses, and so on. And then you have late potentials. The most important late potential is the first one seen on the EEG 1939 by Davis, two Davis, independently, but then they unite. Hallowell Davis and another Davis. They saw this in the raw EEG, and they saw it without any type of magnifying instrument. And this was a so-called slow cortical potential or vertex potential. And it's made of a few waves. We'll come to this at my lecture. Today we speak practical. And they are the long latency potential represented by the P300, which is a cognitive potential or the processing potential, the contingent negative variation, which is the expectancy potential, and then there is the sustained potential. Of course, much later on, many seconds later, you have a skin response, sympathetic skin response or galvanic response, but will not be a topic of what we're going to speak. So, when we come to somatosensory evoked potentials, the best way to classify them is according to the nerve. You do nerves of the upper limbs, nerves of the lower limbs, you do a mixed nerve, you do a sensory nerve, or you do a dermatomal patch. Okay. So today we start with the somatosensory evoked potential studies. When you are dealing with upper extremity somatosensory evoked potentials, we are interested in potentials which will show either at 20 milliseconds for the upper limbs or 40 milliseconds for the lower limbs. Therefore, wisely, we analyze for the upper limbs 50 milliseconds, to see it with a nice window. And you analyze, we are all analyzing 100 milliseconds for the lower limbs. So you have a nice way to see the potential in the middle of the display. Now, in order to do evoked potentials of somatosensory type, you must know quickly that what we are stimulating are the myelinated fiber, the large myelinated fiber, going toward the lemniscal pathway. They go to the posterior columns and they decrussate or cross in the medial lemniscus. They go to thalamus and thalamocortical radiation and the somesthetic area of the brain, posterior to Rolandic fissure. And it was at one point a discussion in a forgotten paper by Yamada and Kimura, where they mentioned forgotten paper. He said, I don't know why, that the spinothalamic can have also a representation to later potentials because it's much slower. The most rapid one is one transmitted through myelinated 1A fibers. And the sensory fibers, as you know from your electromyographic nerve conduction experience, are the thickest one. So this was not proven and is still questionable. But we are not today to discuss theoretical question, but passing by. Somatosensory evoked potentials are done with a scalp recording, and we deal with cephalic and non-cephalic montage. We are not going to do non-cephalic montage. We'll stay here a few days until we can do one. Too much noise. Non-cephalic montage means that one of the electrodes, the active one, will be on the scalp, and the second will be, let's say, on the knee, as was mentioned, or a hand. We are doing a cephalic bipolar montage, which is rapid and gives us the information we need. What we lose in doing a cephalic montage we lose some bumps, small bumps, that are present anyway in 30% of cases or 40% of cases. When we do research, we can afford to do things like this. When we do clinical work, and all of you do clinical work too, I hope, you want to give something which is 100% reproducible. So you lose some by cancellation, because phase cancellation is what they were afraid of in the cephalic montage, but what you see is very reliable. And I tell you from the beginning, the three potentials you will look for when you do upper extremity stimulation will be the Erb's point, or Erb point, because it didn't belong to Erb. It's Erb point potential or supraclavicular potential. And in order to see it, the best channel derivation is from the ipsilateral to the contralateral Erb point, or correct, supraclavicular. This will be, let's say, in channel 1. Channel 2 will be the cervical potential. The cervical potential, we go from the 5th cervical vertebrae, or 7, we are not particular, but I tell you there are German authors like Lovich who is making a fuss about this, and they measure either C3 or C7 and they see the conduction between them. We don't go so far. So the first channel, I repeat for the gentleman from Poland who writes now, is from the EP ipsilateral to EP contralateral. The second channel is from C Roman 5, let's say, to forehead, which is FZ. The forehead, according to the 10-20 system, is 10% from the entire distance, sagittal distance. I use FZ, you can use, PZ is 10, this is 20, 20% is FZ, yes. PZ, yes. But use FZ currently as a reference, interchangeable with PZ. Yes, sir.
Is this ipsilateral, the active one is positive, is that correct? Positive?
What do you mean positive? Ipsilateral Erb's point shows as a negativity. Active is on ipsilateral.
Which is the positive sign here on the channel, you see?
G1.
The reference. I help you with the reference one, same as G1, right?
Yeah, no, the G1 is the active.
Is it an anode or a cathode? That's what I want to know.
Scattered. Of course, it's the active one is ipsilateral.
The conflict with the EMG, which is the reversal.
What do you mean? Where is the EMG reversal? How?
When you do motor potential,
Yeah.
the negative one is the active one.
And so what?
What is the active one? Here, is the positive one is the active one?
No, you make a little, in my impression, respectfully, confusion, because when you say about, you speak about positivity at the vertex, which is a totally different concept. Active one is still the one that you spoke about. But it's a difference between EMG and this. So, CZ is in the middle, but I tell you, second channel, it was a little interruption. I have to come back to my thoughts. At my age, you know, it takes time. Finally, I got back. The second channel will be between, as I told you, between cervical vertebra, the tip of it, and FZ, forehead. And the third channel will be between C3 or C4, or C3 prime or C4 prime, which is 2 centimeters behind C3 or C4, which represent the hand representation in the brain, the sensory homunculus that you all studied. C3 is on the left, C4 is on the right. So you go 20% of the distance between the lobes with tragus from the CZ, which is a vertex. So these are the 3 channels which are working on. But if you want to have a 4th channel, it's very simple. The fourth channel can be, again, instead of C3 or C4, you do a CZ to FZ. We don't need really 4 channels. We need 3 channels when you want to do clinical work. And sometimes you get away with 2 channels. If, for instance, you are interested in the cortical potential, you don't need the Erb's point potential. You go from cervical. Or when you are interested and you are in your private practice area and you have no luxury of 4 channels and you have 2 channels, you can do some work in 2 channels, Erb's channel and cervical channel, or cervical channel and cortical channel. Any problem? Okay. Let me know. Okay. Now, this is the montage that we use frequently, usually routinely in upper limb stimulation. When we do lower limb stimulation, we use 2 channels, conveniently. We use more if you want. But you use as a rule 2 channels. 1 channel, which is CZ to FZ. Now, anybody can tell me why when we do upper limbs we use C3 and C4 and we do lower limbs we use CZ? Because cortical representation of the leg is in the middle. So, perfect. CZ prime, 2 centimeters behind CZ, CZ being the equal distance between the nasion and inion. Okay, that's it. So, this is the first channel, CZ to FZ, convenient reference. And the second channel should be like L1, either to 2 segments above L1 vertebra, or perhaps better to the iliac crest. If you want to do 3 channels in lower extremity, it's very exciting to do the 3rd channel, the same one as cervical channel. And you will be surprised when you do a 3-channel work on the lower limb. Sometimes you see the cervical channel high, very high. The less productive, I mean a good amplitude, I mean. Okay. The amplitudes that you expect in somatosensory evoked potential studies are anywhere from 1 to 10 microvolts, so they are sizable potentials. As I said before, the amplitudes for visual are the largest one are from 5 to 15 microvolts. I speak now about only short latency. And visual, of course, are not short latency, they are always long latency. Visuals are only long latency, as you know. They are only cortical potential, and P100 is the most important, the only important at the present moment, practically speaking. But when you get to auditory, especially brainstem auditory evoked potential, you have very minute potentials of 1/4 of a microvolt. And then, of course, you have to average more. Now you know the channels, now you know the fact that there are parameters that we have to take into consideration. One of them is repetition rate. The repetition rate in somatosensory evoked potential studies is from 2 to 5. Personally, I do 3 per second. Does it?
It'll do 5 or 2.
3, no.
No, 3.
No, 3. We go 5.